Thanks very much, Christine. So I'm an A&E doctor in the west of Scotland and also a clinical research fellow in public health between the Scottish Ambulance Service and the University of Glasgow. And I suppose probably what I hope to provide is a bit of perspective on Navigator from another side, so Navigator from the emergency department. And I think, all of us here today are at a Medics Against Violence conference. So I think it seems likely that this is a group that understands the relevance of Navigator in emergency care, but I think it's really important to understand how this fits in with the work that we do. Because fundamentally, if we were to trust, I suppose, the biggest influence in my understanding of healthcare as a young child, or what emergency care means, then you might think that that might not be something that we're focused on. Because fundamentally, whenever I was a young child, what I understood about emergency departments was from the great American documentary ER. If we have a screen on here, there we go. And if you were to believe ER, you'd think that we would be a group of doctors and clinicians that would be more interested in defibrillating our colleagues, inexplicably intubating in a dinner suit, or playing around on helicopters. Or maybe even if we think about things a bit more seriously in the kind of current crisis in emergency care, maybe we're a group of clinicians that should be more focused on the permanent crisis in our emergency departments. But fundamentally, this work does matter for us in emergency care, and it matters for this reason. And if you speak to members of the public and even some policymakers, they think that your chance of having an emergency condition is equally spread across society. They think that whatever you have doesn't affect you coming to our doors. But fundamentally, that is just not the case. You can pick whatever social characteristic you want, whatever social vulnerability, age, ethnicity, social deprivation, and that will fundamentally change your chances of ending up in our emergency department. And that really happens, I suppose, for two reasons. So the reasons, first of all, are those of access, because fundamentally we are the only place in society now where the doors are always open. If you go back 50 or 60 years ago, it might have been your granny, the priest, the minister. There were other places that you could go, but fundamentally, if you want to be safe and warm in society now, 24 hours a day, the place that you can go is the emergency department. And the second thing that perhaps for those of us in emergency medicine think about less is actually reasons of acuity or illness severity as well. Because just as these factors, social factors, contribute to coming to the emergency department, they also contribute to making you severely and critically unwell. So really core to the work that we provide for society. So if we think about those in turn, first of all, we think about access. So this is data from the Children's Hospital in Glasgow. So this looks at those SIMD quintiles. So this looks at areas of profound deprivation. And what we find is if you live in the lowest 20%, if you live in the most deprived 20% of areas in Glasgow, you're probably about 50% more likely to require admission to the emergency department. And this is not just a Glasgow effect. So we can go all the way around the world, have a look at places like Sheffield. So this is work from Johanna Sutton-Klein there. And what they demonstrated was that your socioeconomic status of the area that you live in, so areas of very profound deprivation and areas of very high emergency department attendance, almost completely overlap. And that can be seen in our departments as well. So this work is currently in peer review for a journal. But what this looks like is trying to take all of the emergency departments in Scotland and trying to work out which are the departments that face the most social deprivation and which face the least social deprivation. And what we find whenever we do that is we find that emergency departments sitting within the most socially deprived areas see about twice the rate of presentations than emergency departments in the most affluent areas. So that has a huge influence on the patients that we see, on the needs that those patients have. And we've already touched upon this. This doesn't just bring people to our doors, it also colours how people present as well. And one of the big things that particularly fueled the work of the family navigators in the Children's Hospital here in Glasgow was some work that had a look at what is the deprivation characteristics across the time of day. So what we find is that if you present at about 9 o'clock in the day, a nice middle class time of the day to come to the emergency department, now you'll find that 9 o'clock to 5 o'clock, lots of middle class parents can get off their work to bring their child to the emergency department during those office hours, whenever we have all of those nice, lovely services. But what if we actually scrape a little bit deeper, what we find is actually it's the out of hours period. It's the after 8 o'clock, it's the 2 o'clock in the morning. Whenever we have those times, the out of hours period, we have a population that is much more socially deprived and much more in need of those extra services that we can put around people. And as I say, so this has an impact on how people's experience in emergency care. And I'm sure that it's not just emergency physicians that have been used to these headlines over the course of the last number of years. So this is the perma crisis of providing emergency care at the moment. And work that we've done in Ayrshire has demonstrated that for the people that are suffering these very long waits, these are much more likely to affect people in the most deprived areas. So if you live in the most deprived 20%, you're about 20% more likely to suffer a wait of more than 12 hours in the emergency department. And these are waits that we know directly affect mortality. So this is compounding harm on the most vulnerable people in society. And again, if we think about those delays on a department level, you're about 31% more likely in those most deprived departments to experience a wait of more than 4 hours. So it's affecting people, but more importantly, but potentially for us who are trying to organise emergency care, the emergency departments in the most deprived areas are seeing the worst of the pressures. But this is not just a problem that is bringing people in to fill our waiting rooms. This is also something that fills our resuscitation rooms as well, because this is not just a problem of access. It's also a problem of acuity or illness severity as well. So if we look at the overall burden of disease across society, chronic disease, we know that the most deprived people in society experience more disease, about twice as much. But if we look at the fatal burden of disease, so these are the conditions that are going to fill our resuscitation rooms, that even more disproportionately affects the poorest and the most vulnerable in society, about 3 times more than the most affluent. And for those of us in emergency care, the main conditions that we want to treat are things like these. These are drug use disorders, this is penetrating trauma, alcohol dependence, and things like COPD, so smoking-related conditions. These are the conditions that fill our resuscitation rooms, and these are significantly more likely to affect the most vulnerable in society. Things like drug use disorders, you're 17 times more likely to experience a drug use disorder if you're in the most deprived 10%. And just as we see that emergency departments in very deprived areas are under more pressure, we also see this in critical care units as well. So this is some work done in Scotland looking at splitting your critical care units or your ICUs into, if those ICUs are from areas of very profound deprivation or from relative affluence, and the ICUs in areas of high deprivation are over capacity for longer to a greater extent than those ICUs in more affluent areas. And fundamentally, this is an injustice, because as a society, we should be putting resource to where it's needed, and all of this evidence describes that we are not allocating resource in proportion to the need. And just to make things worse, work that we have done demonstrates that even whenever you control for illness severity, you're about 13% more likely to die from critical illness if you're in the most deprived groups. So it all looks pretty grim, unfortunately. And I suppose a lot of this brings us to the central problem in emergency care, because every time we face the end point of social vulnerability, and we essentially have little or no means by which to address it, because we're more interested in intubating in our dinner sits. But the sense remains that for some, this might be a reachable moment. And I suppose this is really where Navigator comes in. And for a long time, I suppose this has felt intuitively like it's the right thing to do. And we hear stories from people like Geraldine and her colleagues about the successes of the Navigator programme. But it has been difficult, I suppose, for us to quantify that in terms that are understandable to us in the emergency department, and probably more importantly, the people that fund these services as well. So with Christine, we've undertaken some work that has a look at what the effect of Navigator might be for our patients, for people who present to emergency care. And it's ended up in this paper. So what have we done? We've taken 7 years of Navigator data. Geraldine's given me a heart attack here by telling me that there's 10,000 patients. We managed to find about 1,000 of them. And they're all adults in the services. And we've had a look at how these people's healthcare changes after they have engaged with the Navigator programme. So we've had a look at how they use healthcare services in the year before and how they use healthcare services in the year after. And we've been really fortunate in the west of Scotland to be able to have really quite rich data on how people use healthcare. So we can tell how many times people have been to the emergency department. We can tell how their ambulance use is, how many times they've used ambulance over the course of the last year and the year after, their inpatient stays and their inpatient bed days. And really importantly, I think, trying to see how people engage with planned appointments as well. Because this is not just about trying to stop people using healthcare. Because actually, healthcare is there for a reason. And we know that this is a vulnerable group that needs healthcare. But I suppose what we're trying to say is, does this allow people to engage in healthcare in a more planned way that potentially takes some of those pressures off the emergency departments for a place that we know fundamentally doesn't address those social vulnerabilities that we see? And whenever we have a look at that, we see some pretty startling figures. So in terms of emergency department use, we find a 29% reduction in the year after Navigator programme intervention. We see a 31% reduction in ambulance conveyance to the emergency department. We see a 13% reduction in inpatient admissions to our acute hospitals. And really interestingly for me, we see a 27% increase in outpatient appointments. We also had a look at a group that are very much of interest to us in the emergency medicine community. So these are people who frequently attend our emergency department, so people who've attended the emergency department more than 5 times in the previous year. And actually, we just see results that are even more dramatic. So reduction in emergency department use by 31%, reducing ambulance conveyance by 33%, reducing inpatient stays by even more than that whole cohort, and really importantly, reducing the number of days that people spend in hospitals by 33% in that year. Now, some people in this room might be academics and you prefer your charts with a forest plot with some confidence intervals. You can read that in the paper. Now, I am an academic, so you wouldn't expect me to stand up here and not say that there's some problems with this work. As with lots of things, we've got to just be, I suppose, moderate our enthusiasm a little bit. So this work is retrospective. We've had a look over a large period of time. It doesn't necessarily tell us exactly what the outcomes are now in 2025. I was going to say 2024, but it's not. The other big question, I suppose, for all of us, is this causation? So is this a reachable moment, or is this a moment that has been reached by our patients as well? And I think that what this work doesn't add to it, but we definitely have stories that allow us to say that the Navigator intervention is potentially reaching people at a moment where they're willing to change, but also that the Navigator intervention itself can help to support that change. And I suppose the final thing for me, thinking about where this work is what actually matters to our patients. We can all pat ourselves in the back in the emergency departments by saying this stops people coming to our doors. It might help the crisis that we live and work in every day. But we need to be careful because we're not entirely clear whether that is actually what our patients want as well. So what's next for this work? We're trying to work out, I suppose, whether the benefits that we've seen in terms of use of emergency care, whether that translates into cost benefits for society, for the health service. We're also undertaking a review with the Youth Endowment Fund in England and Wales, particularly having a look at how their youth services help to prevent violence. And finally, I suppose that the big thing for me that I would love to find out is, does this really help in terms of social outcomes as well? So actually staying away from the emergency department only helps our baseline metrics. Maybe it helps us to get through the end of the shift. But I suppose what we really want is to support people into housing, to support people away from drugs and alcohol, and to become fulfilled members of society. If anybody wants to read the paper, you can scan that QR code and it will directly download it. I've also got some paper copies here, and I'm happy to take any questions. You should have it.
Any questions for Ryan? Marian? Can you speak into the mic?
I can, yes. Did you have a control group? And if not, could you?
So really interesting. So for the academics in the world, we used mixed effect regression. So we're able to use each patient as their own control by comparing before and after. So it is, I suppose, a relatively typical, you could argue it's a sort of a relatively conventional before and after study. The question about whether we could do this as a trial, I think, is really pertinent. And I think it's something that we do need to consider it. And I know that there's lots of different views on that in the room. I know that I looked down at Christine, and I suppose what we could say is that what we've shown with Navigator programs and with social support programs is that we really do think that they work. There's lots of evidence that they work in a retrospective way. There's not much done in terms of randomized controlled trials. I think that probably we do need to consider going down that line, but it could be thought as being unethical because we know that these things work, and to randomize people might be tricky. But I think it's something we do need to consider in the long term. And in the meantime, these kind of retrospective studies are probably as good as we're going to get. You look like you want to ask in a follow-up.
was just going to say that if I was somebody who didn't want to fund the Navigators, and I'm not, then I would say that there's been a big societal change, which has meant that these people a year ago were using, and then something else has happened. COVID's moved on, people have got jobs, and by having a comparison group at the same time, you can eliminate that criticism.
Yeah, I think that fundamentally, at some stage, someone in the world is going to do a trial that tries to randomise people to social support from the emergency department or not. I suppose the question for us is, are we the place to do it in Scotland? I think that we've shown that we've got a service that works, so I think we'd be in a really strong place to do it. But it's going to be very technically challenging and incredibly expensive to do. I would love to do it, but I think it's going to be very, very difficult for a program like this to evaluate in that way. But I completely agree. For policymakers, for people that hold purse strings, evidence like that is going to be the strongest thing that we can get. So I think we do need to consider it. Christine's just heard this for the first time, so sorry.
Any other questions? Thank you very much.